Welcome everyone to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I want to give some introductory remarks. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for you to get CME. You will find our evaluations by following the link in the chat at the end of this talk, and our sponsor sends out CMEs in mid-January every year. Your comments are very important to the planning committee and will be used to plan future programs. Dr. Chung, today's speaker, is the director of the Memory Care Center at Queen's, and he has no financial disclosures with commercial entities. It's my great honor to introduce him. Dr. Chung received his bachelor's degree with a magna cum laude in biology at Harvard College. He received his MD at the University of Pennsylvania with a PhD in neuroscience. He was awarded competitive NIMH grants to fund his doctorate research on beta amyloid processing and plaque formation in Alzheimer's disease. Subsequently, he did clinical training, which is medicine internship, neurology residency, and epilepsy fellowship at the University of California, San Francisco. He was then recruited by Scripps Health in San Diego to develop the epilepsy program, where he established epilepsy monitoring unit and the technological infrastructure to offer continuous EEG in the ICU of Scripps Health hospitals. Simultaneously, he worked with the Alzheimer's Project of San Diego County to develop practice guidelines for screening and diagnosis Alzheimer's disease. He has been actively engaged in the ongoing effort to train primary care doctors throughout San Diego County and beyond to utilize these current concepts. Now, with his clinical practice based at Queen's, his ambition is to help develop the best possible dementia care strategy for patients in Hawaii. Please join me in welcoming Dr. Abraham Chung.
Thank you very much for that introduction. I am here to talk about Alzheimer's disease today. Let me share my slide. And specifically, we'll be focused on the disease-modifying therapy in Alzheimer's disease. Can you see my slide okay?
It's perfect, thank you.
Excellent. So, as mentioned, I have no financial disclosures. The objectives for today is to talk about Alzheimer's disease, how to make the diagnosis, both clinically and using biomarkers. We will talk about treatment options for Alzheimer's disease, both symptomatic treatments that are available, that have been available, as well as the new disease-modifying therapy. We'll talk about how to identify the candidates for those treatments and potential benefits and the risks that are associated with those treatments. And so to start out with a photograph, you may recognize this person. His name is Alzheimer. He was a German psychiatrist and a neuropathologist who was working at the Institution for the Mentally Ill and Epileptics in Frankfurt, Germany, where he met this patient. Her name is Auguste Dieter, who in her 50s developed a memory problem. She did not sleep very well. She had language and writing difficulty, and her condition got so bad, her husband was no longer able to care for her. So she was institutionalized, and Dr. Alzheimer was in charge of her care. Over time, she lost almost all of her cognitive abilities and died at the age of 55. Then at that point, having received appropriate IRB approval for that day, Dr. Alzheimer collected samples of the patient's brain and studied it. And what he found was that there was a great deal of atrophy. The brain had degenerated. And looking at the tissue under the microscope, he found two pathological features, the amyloid plaques and the neurofibrillary tangles. And his publication of this finding led to what we now recognize as Alzheimer's disease. Alzheimer's disease causes memory loss, severe enough to qualify for diagnosis of dementia. And what that means is that beyond the normal expected degree of aging, aging-related memory loss, there's a much more significant and much more rapid cognitive decline that happens later in life. Now, later in the course of the disease, towards the right of the curve. Can you see my cursor? Excellent. It should be fairly easy to tell the difference between the normal aging and dementia. The challenge is that earlier in the years, when the difference between normal aging and dementia is rather mild, it can be very difficult to tell clinically. Alzheimer's disease has different stages. You start out with mild stage, where there might be relatively minimal memory loss with very limited functional impairment. And then it progresses to the moderate stage and later into the severe stage of Alzheimer's disease, where they have much greater degree of cognitive impairment. And functionally, the patient is significantly affected as well. Prior to being diagnosed with dementia, there is a preclinical mild cognitive impairment stage where there might be a bit of a memory impairment, but functionally they're not yet impaired. And this is about as much as we can push in terms of early diagnosis based on clinical grounds. What is important to note is that beyond the functional impairment and even the memory test finding that there is some degree of abnormality, there are other pathological features that predate those issues. Amyloid deposition happens first, and then there's tau pathology, and then brain structural changes, including atrophy and degeneration, long before the clinical manifestation occurs. Well, why is this Alzheimer's dementia important for us today? Because it's very common. If you go to the website for the local chapter of the Alzheimer's Association, they mention the statistic of nearly 100,000 kupuna and others in Hawaii that are impacted by Alzheimer's disease or another form of dementia. And in this very large group of people who are affected by dementia, Alzheimer's disease is the most common diagnosis that causes the dementia. More than vascular dementia, Lewy body dementia, frontotemporal dementia, or even dementia-associated Parkinson's disease and others, Alzheimer's disease make up the majority of the patients that end up with dementia diagnosis. And when this diagnosis is made, what treatment do we offer? Up to now, mainly what we offered was symptomatic treatment. You're all probably familiar with the cholinesterase inhibitors. Donepezil is very common. Rivastigmine and galantamine is used as well. And besides the cholinesterase inhibitors, there's memantine, which affects the glutamate pathway. And for a long time, those were the only treatment options that we had available. Then in 2014, reportedly a new option became available and just turned out to be a combination of donepezil and memantine packaged together in one pill. And so there really wasn't nothing new to offer for quite some time. And the frustrating thing about the treatment options discussed here is that these are all symptomatic treatment. So what does that mean? Here's a cartoon depicting what Alzheimer's disease looks like. The cognitive abilities decline over time. Untreated, imagine that this is what the disease course looks like. If we offer somebody symptomatic treatment, maybe there might be some improvement in terms of their symptom, but the disease course, their decline happening over time, that remains unaffected. That is what symptomatic treatment can offer people. What we're really looking for is disease modifying treatment where the actual course of the disease become changed, that they decline more slowly. And if we slow it down enough, it might become disease arresting therapy. Or if people actually improve over time, it would be essentially a cure. We don't have anything that effective for Alzheimer's disease, but we do have disease modifying treatment that can slow down the pace of the decline that we observe in patients. And those treatments approved by the FDA are aducanumab, lecanemab, and donanemab. You probably heard about the news reports of these medicines becoming available. The fact of the matter is that aducanumab was the first agent to be approved through accelerated approval pathway in 2021. Unfortunately, there were issues with regard to how they gained their approval. And they eventually discontinued the availability and it was taken off the market in 2024. The next one that became available was lecanemab, which received full approval as of 2023. And that is the medicine that's available on formulary at the Queen's Medical Center, and it's what we're offering patients today. Donanemab received full approval from the FDA just a couple of months ago, and we have not yet attained formulary approval at Queen's, so donanemab is not yet available at Queen's, but we are working on making that available for our patients. But regarding these disease-modifying therapy, the important point is that the FDA has approved their use only for patients who are still in the early stage of Alzheimer's disease. And that is what has created challenges, because we're talking about a lot of people. In the United States, nearly 7 million people are living with Alzheimer's disease. In the state of Hawaii, as of 2020, more than 30,000 people were diagnosed with Alzheimer's disease. And what that means is that if you collect random patients who are at least 65 years of age or older, 11% of the patients have Alzheimer's disease, meaning 1 in 10 have this diagnosis. That is a staggering statistic. And going through all those patients, figuring out who has the diagnosis and who is in the early enough stage to warrant offering this disease-modifying therapy is quite challenging. So primary care doctors quickly put in referrals for specialists, for geriatricians, neurologists, and psychiatrists to make the diagnosis. Unfortunately, the numbers of specialists that we have available are limited. And so it is really impossible to evaluate all the patients that are requesting to be seen. And so with the delay in getting into the specialty clinics, there's a pushback for primary care doctors to do more in terms of recognizing and diagnosing Alzheimer's disease. But the challenge is everyone is aware how busy primary care doctors are with the limited time that they have for each patient to actually go through the time-consuming memory evaluation. It's just a difficult task for them. And so this is an impasse that the medical field has faced, trying to figure out how we get to the diagnosis for patients who might qualify for the treatment, not really making a lot of headway. Now, obviously, the conversation that we do not want to have with our patients is this one. For someone who gets diagnosed with Alzheimer's disease, for them to say, if I had been told about the new treatment option in time, I would have asked for it. But now it is too late for me. This is the situation that we want to avoid. And so I think every clinic will have to figure out their way to resolve this issue. And I'll just take a moment to explain how we are approaching this at Queen's. We have created this model for a cognitive assessment pathway. And what's depicted here is the traditional method where the primary care doctor hears about a memory complaint, and then they'll put in a referral for a specialty, typically neurology or geriatrics, or more likely than not, they'll put in a referral for both to see who can get the patient in sooner. But that kind of approach only overwhelms the system. It's extra work for the staff. It delays further the patient's access to specialty clinics. And so that's why we decided to approach this a little bit differently. What we're doing is we're training licensed social workers. The social workers will be able to do the cognitive testing like Montreal Cognitive Assessment. They will do an informant questionnaire using 88. They can do a PHQ-10, PHQ-9, and other type of assessment that will help the primary care doctors to make a medical decision. That information will be sent back to the primary care doctor, who can then decide whether the patient's condition is pretty mild and not really warranting specialty evaluation, and they will continue to manage those cases. If there is significant cognitive impairment, depending on the stage of the dementia that they're in, they will either refer the patient to neurology or geriatrics. And this way, streamlining the evaluation and putting in the referrals for the specialties, hopefully we'll be able to go through the backlog and meet all the patient's needs. Now, of course, this help is useful for the primary care doctors, but they do need to be able to recognize and diagnose Alzheimer's disease. And that's where this guideline comes into play. I had the fortune of working with the Alzheimer's Project of San Diego to work with specialties including neurology, geriatrics, and psychiatry to come up with a practical guideline that primary care doctors can use to recognize and diagnose Alzheimer's disease. If you would like a copy of this guideline for yourself, there is a QR code down in the corner of the screen. You can use your phone, download the guideline, and review it at your leisure. The point was that this is not a problem that's limited to here in Hawaii. It's a problem that's nationwide, worldwide, actually. And San Diego recognized that this is something that we need to address sooner rather than later. And recognizing that we just don't have the numbers in the specialty clinics to meet the demand. The strategy that they came up with is to come up with these guidelines that primary care doctors can use to diagnose Alzheimer's disease. And if you do look up the guidelines, there's basically two straightforward algorithms. One is for screening patients to see if there is a memory problem worth evaluating, and then a more rigorous evaluation algorithm that can take you to the diagnosis of Alzheimer's disease or different type of dementia. The point is, you go through the exercise to rule out reversible causes, and you go through the algorithms to rule out things that may not be dementia. And ultimately, the primary care doctors are left with placing patients in one of three categories. One is a dementia with an atypical feature, meaning that it's probably not Alzheimer's disease. Those patients should be referred to a specialist for further assessment, be it neurology, geriatric, psychiatry, whoever is most appropriate. The remaining categories are presumably patients who have Alzheimer's disease, and they're divided into patients who have moderate to advanced dementia, who may be best served by being managed by geriatrics, or patients who are still in the MCI or the early stage of Alzheimer's disease. Those patients should be fast-tracked to neurology for a consultation so that they may be evaluated to determine their candidacy for the disease-modifying treatment. That is the approach that we're taking. And if the patient does end up in this mild cognitive impairment to early stage dementia and they're referred to neurology, the first thing that we're going to do is confirm the diagnosis by using biomarkers. And the gold standard for diagnosing Alzheimer's disease is a PET scan. Now, this is not the PET scan that I'm talking about. This is the standard FDG PET, which can be useful in certain circumstances. It's basically looking at metabolism of a glucose molecule linked to a radioisotope and comparing someone who is normal. There's a pattern of decreased metabolism, which may suggest Alzheimer's disease, or a different pattern that may suggest frontotemporal dementia. And that is where FDG PET might be useful in certain cases. Instead, the PET scan that I'm referring to is the one that can stain for amyloid deposition. So meaning that the radioisotope is actually linked to a molecule that binds amyloid in the brain. You can see that in panel A, the signal is rather weak. You can see in panel B that the signal is rather strong. The strong signal indicates amyloid burden. So the patient in panel B has Alzheimer's disease. The patient in panel A does not have Alzheimer's disease. So when you're comparing someone who is cognitively normal to someone who has Alzheimer's disease, particularly in rather advanced stage, you may be able to tell the difference clinically. But where this PET scan becomes very useful is earlier in the disease course when two different patients have mild cognitive impairment. So clinically, they look very similar, just with a little bit of cognitive deficits. And when you do the PET scan, you'll see that one patient has very little amyloid deposition. Another patient has a lot more amyloid deposition. And you can tell that early in the clinical course who is more likely to end up with Alzheimer's disease over time. And that way you can identify people that qualify for this treatment. The bad news is that this amyloid PET scan is not yet available in Hawaii. The good news is that Queens Medical Center is working on developing that technology, and we are anticipating that we'll be able to make that available to patients in 2025. So hopefully in the early stage of 2025, but I lived in Hawaii long enough and I've ordered things from the mainland and I know that things take time. So I've been told that there might be some delay, but sometime in 2025, we hope to be able to offer amyloid PET scan to our patients. So until that happens, how are we actually diagnosing patients with Alzheimer's disease? Well, we're using CSF studies. We're analyzing the cerebrospinal fluid to confirm that the diagnosis is in fact Alzheimer's disease. And why do we bother with the biomarkers? Because that is a lot more accurate than the clinical assessment done by either the dementia specialists like geriatricians and neurologists, where we score in the accuracy somewhere in the 70% range. That is better than primary care doctors, whose accuracy rate is more in the 60% range. But using biomarkers, we can be fairly confident with 95% accuracy that the diagnosis is in fact Alzheimer's disease. And so let's talk about these available biomarkers. Comparing the CSF analysis with the PET scan using the single cutoff approach, you can look at the positive predictive value, negative predictive value, sensitivity. The accuracy is in the 90% range. And then if you use the two cutoff approach, the accuracy actually improves to 95% range. And this is what's being utilized these days. But what does that mean? Well, if you use the PET scan to detect whether there's amyloid present or not, and depict the patients who tested positive by amyloid PET scan in blue and those who tested negative in gray, and then simultaneously test the same individuals using the CSF evaluation to see who tests positive and who tests negative. Well, you get these two peaks in the histogram. Presumably, these patients are in fact positive for Alzheimer's disease diagnosis, and these patients do not have Alzheimer's disease diagnosis. If you use the single cutoff approach and identify these patients as having Alzheimer's disease, your accuracy is in the 90% range because you do have some patients who are supposed to be negative showing up in that portion of the analysis. But if you use the two cutoff approach, where you identify people to the right of this line as being positive and people who are left of this second line as being negative, the accuracy improves to 95%. So that is the benefit of the two cutoff approach, that the accuracy improves. The downside of this approach is that there are these patients in the indeterminate range where they're not identified as having Alzheimer's disease, even if they do have Alzheimer's disease. But this is the closest we can get short of a PET scan. Using CSF evaluation, we can have 95% accuracy in terms of making the diagnosis. And the new development these days is that they're using a similar approach to test blood to see if somebody has Alzheimer's disease or not. And there are multiple publications that are coming out that the accuracy using the similar two cutoff approach, testing blood compared to CSF, you still get up to 95% accuracy for making the diagnosis. And that was quite surprising. And so with more publications coming out like this, it may be that pretty soon there will be utilization of blood tests instead of CSF evaluation for diagnosing Alzheimer's disease in the future. But still recognize that because of this indeterminate group of patients, there will always be a role for using a PET scan to confirm the diagnosis when you have your suspicion, even if these tests come back negative. So using this biomarker approach, if you do confirm the diagnosis of Alzheimer's disease, well, what does the disease modifying therapy do? So brief background about amyloid. The amyloid peptide that we're talking about comes from a much larger protein called amyloid precursor protein. And if this amyloid precursor protein is cleaved in the right location, it releases the pathogenic amyloid beta peptide. And so what we understand about how Alzheimer's disease develops is that it starts with the amyloid precursor protein. And through the metabolism of that precursor protein, you get soluble forms of A beta, which may aggregate and turn into the amyloid plaques that are seen in the brain. And there may be some back and forth between these different forms of amyloid, but the presence of amyloid induces glial, vascular, and neuronal cell changes, which presumably then cause the tau pathology to develop, which causes neuronal death, and that's how we end up with cognitive impairment. That is our general understanding of how Alzheimer's disease works. And so the treatment that we're talking about, lecanemab, was designed to clear away the soluble forms of A beta and donanemab was designed to clear away the amyloid plaques that have deposited in the brain. And both of these approaches have been shown through clinical trials to be fairly effective for clearing away the amyloid burden in the brain using amyloid staining PET scans. And so the degree of amyloid deposition clearly diminishes over time with treatment using not only donanemab, but also aducanumab and lecanemab. They're all very effective in that way. And as the amyloid gets cleared away, what they've shown is statistically significant change with regard to how fast the patient's clinical status declines over time compared to placebo. Now, I wish the change that they noticed in this clinical side of things was much more robust. It's not really obvious how much degree of change the patients are experiencing just from observing them. But through careful clinical testing and statistical analysis, they were able to show that there is a disease-modifying effect, that the pace of the decline of their clinical condition is changed when they are treated with these medicines. Now, the two choices that we have on the market right now, lecanemab and donanemab, there are slight differences in the protocol that was developed for the clinical trial. And let's just kind of talk about that for a moment. Lecanemab infusion is done every 2 weeks. It is a pretty significant time commitment of trips made to the infusion center for that treatment. By comparison, donanemab infusion is every 4 weeks. It's still a lot of trips to the infusion, but half as often, and that makes a big difference. The clinical trial for lecanemab went for 18 months. The clinical trial for donanemab went for 76 weeks. Now, the key difference is that lecanemab, people who receive the treatment continuously receive the treatment for the full 18 months of therapy. And then upon conclusion of that clinical trial, they started an extension phase where those patients continue to receive the treatment to see if there is a benefit to keep giving lecanemab indefinitely. And we don't have published results yet, but the representatives for the drug company are telling me that preliminary results are saying that probably patients receiving lecanemab will need to continue to get lecanemab even after the 18 months. On the other hand, donanemab clinical trial was done in a way that there was follow-up PET scans with amyloid staining done at 24 weeks and 52 weeks. And if they demonstrated that the amyloid has cleared away, they were actually taken off the medicine. And at the conclusion of the trial at 76 weeks, the treatment was stopped. And so there's a more defined exit strategy in terms of people that get started on donanemab. And so how these different approaches for treatment will evolve in the future in terms of people getting lecanemab versus donanemab and how long the treatment should go for, that is something that we're going to be debating. And it'll be very interesting to see how that turns out. Now, in terms of who can get these treatments, initially it was only Medicare that agreed to pay for the treatment. But more recently, HMSA has agreed to cover the cost as well. And hopefully the remaining private insurances will follow suit and offer to cover the costs. But the thing to keep in mind is that even when there's insurance coverage, because we're talking about infusion therapy, everything is expensive. I mean, the medicine alone for 1 year's worth of treatment is going to be tens of thousands of dollars. And then there's the cost of the infusion center, the nurse's time, use of equipment. We're talking about a lot of money. And so taking Medicare as an example, where when they do cover the treatment, it's about 80% coverage. Well, 20% responsibility for the patient, 20% of tens of thousands of dollars, it's still going to be a lot of money. And so not everyone is going to choose to go with the treatment, even if they are eligible. So these are the kind of issues that you need to discuss with the patient to see who will actually go ahead and receive the treatment, who will not. Now, besides the time burden of going to the infusion center for repeated treatment and the financial burden that some people may find difficult to bear, there's also the potential concerns for side effects or complications that come with the treatment. And the one that we really worry about is ARIA, that is the amyloid-related imaging abnormalities. I'm sure you've heard of it. All the medicines in this class of that take away the amyloid burden from the brain have been associated with ARIA. Lecanemab, donanemab, aducanumab, they all cause it, and in fairly significant percentages. We're not talking about a very rare complication. It happens a lot. And therefore, both lecanemab and donanemab require follow-up MRI scans to monitor for this abnormality. And there is particular concern that people who have the epsilon 4 allele of the ApoE gene are more likely to develop this type of a complication. And so, for example, in this slide with lecanemab, compared to someone who's a non-carrier who may be at 5.4% risk for the ARIA-E, that's the edema form, someone who has one copy of the epsilon 4 have almost 11% chance of developing ARIA. And for someone who has two copies of that, almost 33%. That's a big jump. And for donanemab, similar issue compared to a non-carrier where they noticed about 15% chance of ARIA-E. Heterozygous carrier have 22%. For homozygous carrier, it's more than 40%. And so fortunately, they do say that majority of the patients who develop the ARIA, either ARIA-E, meaning edema, or ARIA-H, which is hemorrhage, that many of them are asymptomatic, and these are things that we just see in the imaging studies. But some people do develop symptoms, and rarely, for those people that do develop symptoms, the outcome can be catastrophic. So here's one example. It's a published report of a patient who participated in the clinical trial for lecanemab. She completed the clinical trial in the placebo wing. And so the clinical trial was completed. Nothing happened because she did not receive the medicine. At the conclusion of the clinical trial, they had an open label extended trial where she was offered lecanemab, and she elected to do that. After receiving 3 infusions, she went to the emergency room with seizures. Despite receiving anti-seizure medicines and high-dose steroids, her condition deteriorated and she died in 5 days in the hospital. It is notable that she had 2 copies of the epsilon 4 of the ApoE gene, so we knew that she was at higher risk. And in this publication, they showed what the ARIA looks like. So up here is the pre-treatment MRI scan that they obtained, and down below is the post-treatment MRI scan. You'll see that compared to pre-treatment, there's a lot of signal change going on post-treatment. And you'll see that the sulci is harder to see, meaning that there's a good deal of edema happening in the brain. And in addition, if you look at the susceptibility images, you'll see that there was a couple of microhemorrhages before the treatment, but there were more after the treatment. And regarding these microhemorrhages, don't be fooled by the fact that they look so small in these MRI scans. If you get a higher resolution MRI scans, you'll see that the degree of injury to the brain surrounding those microhemorrhages are greater in appearance. And in the post-mortem evaluation, you can see that there is a good deal of damage in the brain associated with the microhemorrhages compared to the signal changes that we see in the MRI scan. So even if you see just a few more microhemorrhages, this is not something to take lightly. Because of this concern for ARIA complication, there's appropriate use recommendations that have been published that everyone should abide by. And they have rigorous exclusion criteria for patients who should not be receiving lecanemab. And among those, people who have history of brain bleeding, history of significant cerebrovascular disease, and anyone who's at high risk for bleeding because they're on anticoagulation, they should not be receiving this treatment. And we do need to be careful about checking for ApoE genotype status, especially for those who have 2 copies of the epsilon 4 variety. They should be strongly cautioned against receiving this treatment because of the concern for ARIA. What I will say is that at Queen's, our experience has been this. So far, we have 4 patients receiving the treatment. The number of infusions that they received to date are mentioned here, and I've also listed their ApoE status. We have run across at least one patient who was potentially eligible, but he had 2 copies of the epsilon 4 allele. And after an honest conversation, the patient decided not to go ahead with the treatment. And there are a number of other patients who clinically was found to be potentially eligible for treatment, but either because of concerns for ARIA or concerns for the financial burden or concerns for making such frequent trips to the infusion center that they declined the treatment. But it is important that the patients and their families have the opportunity to make this decision themselves, as opposed to being too late in terms of making the diagnosis and having the decision made for them. So before we finish this talk, I'd like to take us back to this slide, which is a model of what we understand how Alzheimer's disease works. First, there's amyloid deposition, and then there's tau pathology, and then we see brain degeneration, and that's followed by memory loss. And when the memory loss gets bad enough, we see clinical functional decline. But there was an update to this model, which I'll show here. So after all the pathological changes, the clinical effect, it's not the same for everyone. There is variability. Some people tend to develop dementia early in the presence of the pathology. Other people are relatively protected and develop their memory decline and functional decline later, even with a similar degree of pathological burden. And that is presumably due to their response or the presence of risk factors. And so the Lancet Commission has been reviewing literature and publishing from time to time what they see as potential risk factors for Alzheimer's disease, with good evidence that they are really playing a role in terms of patients getting Alzheimer's disease. And they just published an update just this year in 2024. And so this figure kind of summarizes the different factors that could be at play. And what we find is that in terms of risk factors, it starts very early in life. How much education somebody gets can have an impact later on in terms of whether they end up with Alzheimer's disease or not. This kind of information can be very important to policymakers. If you do not want to deal with the financial burden of large portions of the population getting Alzheimer's disease, make sure that everyone gets educated early in life. During the midlife, there can be hearing loss and high LDL cholesterol level, which seems to have more of an impact in terms of whether people get Alzheimer's disease. There are other conditions that have been identified, including depression, traumatic brain injury, physical inactivity, diabetes, smoking, hypertension, obesity, and excessive alcohol. Oh, and by the way, within the circles, it mentions the percentage rate of how much of an impact these different risk factors may have in being diagnosed with Alzheimer's disease later on. And beyond the midlife stage, in the late life stage, when patients are actually more likely to get diagnosis of dementia, those who are in social isolation appears to be at higher risk for being diagnosed, along with others who are exposed to air pollution and those who have vision loss. So if you look at the numbers, most of them in single digits, they may not seem very impressive. But the fact of the matter is that if you address all these risk factors, almost half the patient will either not get Alzheimer's disease, or at least their diagnosis will be delayed significantly. This is a significant benefit to the patients. And so to summarize, rather than waiting until somebody has clinically obvious dementia and offering symptomatic treatment, it's better to diagnose the condition early and offer disease-modifying therapy. But even better than that, what we would really like to emphasize for the future is recognize much, much earlier on, even dating back to childhood when people are getting educated. Take care of the risk factors, treat early, long before they get diagnosed with Alzheimer's disease. And it's probably going to be a combination of both addressing the risk factors and new treatment options that become available that is going to have a serious impact on people being diagnosed with Alzheimer's disease in the future. So in conclusion, Alzheimer's disease is the most common cause of dementia. And there are tools available for diagnosing Alzheimer's disease, both clinical and in terms of using biomarkers. And when the diagnosis gets made, there is treatment available for people who have Alzheimer's disease, treatment that are both symptomatic and disease modifying, and recognize that there are more options available for people that get diagnosed early. And so evaluating and diagnosing Alzheimer's disease early is clearly important. And for those people who are considering disease modifying therapy, there are potential benefits of the treatment that's being offered. And there's also risks that can go with the treatment, such as ARIA that we discussed. But the point is that there is new treatment that's becoming available and better understanding of what the risk factors are. And so the message that I'd like to convey is that there is hope for new and better treatment options in the future for people that get diagnosed with Alzheimer's disease. And I'll just put this slide back up with the QR code for the practical guidelines. If anyone is interested, you can use the QR code to download a copy of the guideline for yourself. And please feel free to circulate this to anyone that you think might be interested, any primary care doctors or others, colleagues of yours that might be wanting to see what this guideline looks like. Feel free to send it to them. Thank you very much for your attention.
Abe, thank you so much for such a wonderful presentation. That was a really nice overview of all the new changes that are happening, many new changes in the last few years. For our audience, if you have any questions, please go ahead and unmute yourself and ask the question, or you may type it in the chat box if you'd prefer. Any questions for Dr. Chung?
Either I was very clear or it's clear as mud.
No, you did a wonderful job. I guess I'm not sure if anybody knows the answer to this, but for the lecanemab studies, the studies that I saw went 18 months. Obviously, this is a long-term disease. What are your thoughts about long-term effects of this medication?
Yeah, that's a very good question, and there's no clear answer. The big concern that we have about treatment with lecanemab is ARIA. And experience shows that patients who are susceptible for getting ARIA will probably get it early in the treatment course. And so there are a lot more MRI scans scheduled early in the course of the treatment and fewer later on. And so if beyond the 18 months, there's going to be continuing treatment, I imagine from time to time, there's going to be some scheduled MRI scans, but probably not very often. It's going to be more monitoring for symptoms and ordering MRI scans as needed. But there's just something inherently worrisome about ongoing treatment with no end in sight. I just don't know whether that makes sense. And in that regard, I think donanemab can be appealing to people, where when it becomes available, there's an obvious start to the treatment, and there's a plan for end of the treatment. And ultimately, in the end, I imagine it may actually be a combination of donanemab and lecanemab that will ultimately be the recommended treatment for people who get diagnosed with Alzheimer's disease. But we'll just have to wait and see.
Okay, thank you. There's one question in the chat. Anna is curious about how the patients undergoing lecanemab infusions at Queen's have responded in terms of their cognitive function.
Yeah, that's a very good question. Obviously, we have not been doing the treatment for a very long time. We started sometime in April or May with our infusions. And so far, what I can say is that no one has experienced ARIA, which is good news. But ARIA is anticipated to occur because statistically, a good number of patients receiving the treatment do get it. But so far, so good. I will mention that there are others on the island who are receiving lecanemab elsewhere who presented to our emergency room with ARIA. And so it does occur. And that does beg an important question. What we do worry about is people with microhemorrhages, people with bleeding. And so patients showing up in the emergency room with stroke-like symptoms, receiving thrombolytic therapy, that is a big time concern. And I know that within Queens, we've been having a lot of conversation about how to protect our patients, and we have put hard stops in our EPIC, the electronic health record system, so that if anyone tries to prescribe anticoagulation or thrombolytics in someone receiving lecanemab, there is a warning message that pops up that that's probably not a good idea. But the scenario that we worry about is patients who are receiving the treatment elsewhere outside of Queens who end up in the emergency room. And the emergency room staff, how will they know whether thrombolytics is appropriate treatment for them or not? And so we are initiating a conversation with all who might be interested to try to come up with a straightforward signal to warn the emergency room doctors about potential risk in that way. Maybe in the form of a bracelet, a recognizable bracelet that all of these patients will wear that will preclude use of thrombolytics if they show up in the emergency room. But I do hope that all of you who are in attendance will be supportive of that effort. And if any conversations come up about whether something like that is necessary or not, please do emphatically tell people who can make decisions about this that it is important and it is necessary. In terms of their cognitive status in the short phase of treatment that we have experienced at Queens, there has not been any significant decline, but no significant improvement either. We will continue to monitor them, and I can update you in the future if we find anything.
Thank you, Abe. Lori's asking, have there been Queens patients receiving lecanemab who've experienced any other side effects?
I'm sorry. What was the question?
This is
Somebody
about.
told me that I was still sharing my screen. I had to close it.
Oh, sorry about that.
Yeah.
Yeah, somebody's asking, are there Queens patients receiving lecanemab who've experienced side effects? You mentioned we haven't had ARIA, but any other side effects that we've noticed?
Other side effects are typically the infusion reactions. That's the main stuff. I am not aware of any other significant issues that we've run into. And it looks like the question is who else is offering lecanemab? And so Hawaii Pacific is clearly offering lecanemab. And I don't know exactly who, but apparently there are others. But we'll have to come up with some way of making sure that all of the providers that are offering lecanemab is involved in the conversation about how to work together to safeguard our patients.
That makes sense. Any other questions? Justin has put in the clinical guidelines booklet link into the chat. Thank you, Justin. So you can just click on that link and download that PDF. Oh, Kaiser is as well, somebody said. Kaiser is offering lecanemab as well. So good to know.
Yes, good to know. Thank you so much.
I know the local VA is not, although the national VA has approved it, but the local VA is not, and they're actually sending people to the mainland, although that's not very practical for something that needs to be done quite so often.
Yeah. Agreed. One thing that is in the pipeline is the company that makes lecanemab is working on a subcutaneous version of the medicine. And so it is anticipated at some point that that will become available. Once that happens, the VA system might have a little easier time having a centralized clinic that offers the treatment, but the patients don't have to show up there in person for the infusions. We'll see how long that takes to become available.
Right. Any more questions? Okay, we'll give people a minute. If you'd like to unmute yourself and ask your question, you certainly can. And John has put the link for the CME. It's an evaluation form, and you need to do that in order to get CME. For any of you who want to get CME, please click on that link and fill it out. Any other questions for Abe? Abe, that was such a wonderful presentation. We really appreciate you doing this. And yes, we would like you to come back at some point and give us updates as more updates come along.
Yes, I'm happy to do so. Thank you for inviting me.
I did want to mention to our audience, The Queen's Geriatrics Department has a biennial conference, and the next one is going to be in April of 2025. It's going to be on Good Friday. I think that's April the 18th, 2025. And Dr. Chung is going to be one of the speakers at that conference, as well as many others. And that conference, the focus is going to be on dementia. So it's going to be a very good agenda with very good speakers. So I encourage people. I don't think the registration is out yet, but save the date on your calendar anyway. Okay, it looks like we don't have any more questions. So, Abe, I want to thank you again for really a wonderful presentation, and thank you for working with us on the clinical side as well to get our patients better care.
Thank you very much.
Okay, bye everyone.